Hello. Hello.
Yes, sir.
Yes, sir. Start presenting. Okay. Am I audible, sir? Am I audible?
Yes, sir.
Okay. Thank you so much. Okay. Good afternoon, everyone. I am Dr. Sultan Al Rashid. I am Assistant Professor of Pharmacology from Savita Medical College and Hospital. And my co-author is Dr. Syed Ziaur Rahman. He is from the Department of Pharmacology, professor from Jawaharlal Nehru Medical College, Aligarh Muslim University. Thank you. My topic is ciprofloxacin-induced peripheral neuropathy in a diabetic patients. So what are the causes for ciprofloxacin-induced peripheral neuropathy in a diabetic patient? They are going to describe with this report. So with a possible explanation of its mechanism of action. So coming to the background, the peripheral neuropathy, is a rare and serious adverse reaction to the fluoroquinolones. However, the mechanism of action is not clearly known. So coming to the aims and objectives, we try to explain the various scientific perspectives related to the pathogenesis of ciprofloxacin-induced peripheral neuropathy, particularly in the diabetic patients we have seen. Methodology, so after receipt of few cases, we have received the ADRs from the our hospital wards. So we have analyzed after evaluating the casualty assessment. So we have received the patient in our hospital received an ADR report of 38-year-old female, Mrs. P, who was admitted to our septic ward with the chief complaints of right foot diabetic ulcer. The patient had been known case of type 2 diabetes mellitus for 13 years. The patient was on 3 oral medications, lamipiride, metformin, and vildagliptin, and she was admitted for diabetic ulcer. So, to reduce the severity of the ulcer and expected infection, the staff nurse gave the injection ciprofloxacin as a test dose. After giving the test dose, she developed a burning sensation all over the body. So she developed peripheral neuropathy very immediately. So, in our opinion, after analyzing all those things, we have analyzed there are multifactorial causes that synergistically aggravate the ciprofloxacin-induced peripheral neuropathy in a diabetic patient. Coming to the discussion, the deficiency of B vitamins, particularly the vitamin B12 and folic acid, this is an important cause of the peripheral neuropathy. Moreover, the vitamin B12 and folic acid levels are found to be low in the patients with diabetic neuropathy, and there is a strong association between the diabetic neuropathy and duration of type 2 diabetes and the glycemic control. Our patient here was diabetic for past 13 years, and she was had a high chance she had developed diabetic neuropathy, which went unnoticed. So the disease itself can induce peripheral neuropathy, which can be exacerbated and unmasked by taking ciprofloxacin. The patient had been taking metformin for the past 13 years. We know that the chronic intake of metformin was associated with the vitamin B12 deficiency. There was a similar case report of ciprofloxacin-induced axonal neuropathy in a 62-year-old male who exhibited the folic acid deficiency. As we know, the ciprofloxacin is one of the important antibiotics which causes the superinfection. So, since it causes the superinfection, it alters the growth of the bacterial flora. We know that the vitamin B12 and folic acid are the most importantly synthesized from the bacterial flora. If you are using ciprofloxacin, it alters the bacterial flora, so the vitamin B12 and folic acid will not be produced, which leads to deficiency, vitamin B12 and folic acid deficiency. All these factors can synergistically aggravate the ciprofloxacin-induced neuropathy. So our conclusion is if the patient is diabetic for longer time, they may have developed diabetic neuropathy. That itself can produce acute peripheral neuropathy. And if the patient is taking metformin for a long time, it can produce vitamin B12 deficiency. That can produce peripheral neuropathy. Ciprofloxacin use can alter the bacterial flora, so the bacterial flora will be disturbed, which will not produce vitamin B12 and folic acid deficiency. So there are multiple factors that can aggravate the ciprofloxacin-induced peripheral neuropathy. So we have to be very careful while giving ciprofloxacin to the diabetic patients of long duration. Thank you so much. This is my case report.
Hello, hello.
Hello.
Hello, hello, hello. वन में है, मेरा वाला वन में है। हेलो हेलो
Hello. Are we audible? Someone please respond on the chat box whether we are audible or not. Chat box we just get. So, first request the first presenter to please, I think he was presenting the session, but we were not able to hear the delegate. So, I request the first person to please respond to the question answer session, and we will just give it 1 minute, but actually, you can just answer the question answer session. And we are just projecting your poster from our side, and you can just answer the question and register for the
Hello,
Yes, sir.
Dr. Sultan. Yeah. So
Yes, sir.
your title is ciprofloxacin induced peripheral neuropathy in diabetic patient, right?
Yes, sir.
So,
Yes, sir.
So why do you think that this peripheral neuropathy is because of the ciprofloxacin?
Because there are a lot of factors, sir. Because
No, you yourself has mentioned that the peripheral neuropathy may be because of the diabetes also, right? And
yes, sir.
patient was having long-standing diabetes. So this peripheral neuropathy may be because of diabetes also.
Yes, sir. Both the diabetes and ciprofloxacin synergistically aggravates and precipitates the acute peripheral neuropathy. Because we are given the test dose of ciprofloxacin, suddenly she developed a burning sensation.
It may be because of diabetes also.
The patient is diabetic also.
Yeah. So how we can say that this peripheral neuropathy is because of ciprofloxacin when the patient is already having long-standing diabetes?
The patient is having long-standing diabetes, but she didn't mention she has diabetic neuropathy. There is no history of diabetic neuropathy in this patient.
Okay. I'm handing over the mic to the second judge.
Yes, sir.
Dr. Sultan, I would like
Yes,
to
sir.
ask, is there any correlation between the drug dosage of ciprofloxacin and its frequency and the duration of treatment of ciprofloxacin? Is there any correlation which you found during this case report study?
No, ma'am. This is an ADR report. We collected the ADR details and we just mentioned it.
I guess you didn't understood my question. I'm asking
Yes.
about this particular patient, for how long
Okay.
and for how much dose the ciprofloxacin was used.
Only test dose is used. No dose is used. Only test dose. She has diabetic ulcer, so they have given the test dose to check for allergy. So they just given 0.5 milligram of ciprofloxacin. Suddenly she developed burning sensation. Only test dose is used.
Next one, please. Dr. Soumya Singh. Dr. Soumya Singh. Dr. Soumya Singh. Am I audible? Dr. Soumya Singh, are you there? So we'll move on to the next candidate, Dr. Sneha Lade.
Yes, ma'am. I'm there.
Yeah, please start.
So, yeah, good afternoon, everyone. I am Dr. Snehal Lade. I'm from Lokmanya Tilak Hospital, Sion, Mumbai. I'll be just highlighting the important points of my study. So, the aim and objective of our study was to assess the knowledge, awareness, and attitude of pharmacovigilance among interns, postgraduate residents, and faculty of clinical departments. I'm sorry, ma'am. I'm seeing someone else's poster right now on my screen. Should I continue? Should I continue with my poster?
Yes, please, you can continue.
Okay. So there, we took 150 participants, 50 each, 50 interns, 50 residents, and 50 faculty. They were given a pre-validated questionnaire with 20 questions, which included questions like where to report an ADR, who can report an ADR, ways to report ADR, objectives of PVPI, what is the WHO online database, so on and so forth. We observed only 2% were very well aware, while 77% were less aware about the pharmacovigilance. The major finding of our study is 48% participants have not reported any ADR so far, and 39% were unaware of reporting procedure. So while concluding our study, I would like to say this study documents the perceptions of pharmacovigilance among various study participants and the need to report ADR. The study highlights low awareness and gap in.
Ma'am, I'm not seeing my poster, and that is why I was sharing.
I'm really confused. Should I continue?
Snehal,
Yeah.
we are able to see your poster on our screen, so don't worry about that. Right.
Okay.
You go ahead with your.
Okay. So the study is highlighting the low awareness and gap in knowledge regarding pharmacovigilance and necessitating the training among the healthcare workers. So thank you. That was the conclusion of my study.
Okay, so Dr. Snehal, my
Yeah.
question is, what do you think? What can be the reason for low awareness about the this thing pharmacovigilance?
Sir, mostly the clinicians are scared that they will be accused of the ADR, that it is caused because of their negligence, or they are also scared of the fact that it is showing their.
How did you collect the sample? Was it random sample or it was purposive sampling?
It was random sample, sir. We approached clinical faculty with the Google Forms, We did
Yeah.
not keep any specific criteria for them.
So you requested every.
Yeah, we forwarded the Google form, sir, in our institute.
Don't you think those who did not responded may have something else to say as compared to those who were responded?
Yeah, sure, sir, they might. But most of the workload is so heavy. Sometimes that is also one of the reasons that they are not reporting it, or they are not even giving the importance to report the area, sir.
Okay.
So they just need a proper training for the reporting system, that it is not that hard to report a area.
Dr. Snehal?
Yes, ma'am.
I would like to ask about that when you took these questionnaires, so
Yes, ma'am.
how was you sure कि all these persons from whom you have taken, interns, residents, and faculty, they were not trained beforehand or they were not sensitized beforehand?
I'm not sure they were sensitized or not, but mostly in our department, we get areas from these faculty and these residents only. And being a student from same institute, I wasn't sensitized for the pharmacovigilance. So that's why I approached my interns through this Google form. So I'm pretty sure the interns weren't sensitized about this
But
pharmacovigilance.
that could lead to bias in your study, right? So there might be some pre-questionnaire or something like that, like a screening sort of thing. Those who have not being trained, and those who have been already trained or sensitized. So the result would have been more accurate then, right?
Yeah, ma'am, it could have been.
Okay, thank you.
Thank you, ma'am.
Dr. Soumya Singh next, please.
Yes, ma'am. My study is about Pesolimab. This is a novel drug which has been used. Am I audible? Hello?
You're audible, yes.
Yes, sir. My study, my review is about Pesolimab. It is a novel drug which has been discovered, which has been prepared from by Boehringer Ingelheim for the generalized pustular psoriasis. This is a condition in which there is a pustules which develop all over the body. It's a very painful condition, and it causes many problems, including cardiac failure and renal failure, because it leads to electrolyte imbalance in the body. For this Pesolimab, it is an intravenous drug which has been prepared, and it is given intravenous, and some adverse effects which has been seen with this are most common. It includes skin rashes, which have been seen in majority of the clinical trials, followed by acne. Some patients have reported asthenia, fatigue, nausea, vomiting, pruritus, prurigo. Nasopharyngitis was also seen very rarely in few patients, and it is a very safe drug for the immunocompromised patients with generalized pustular psoriasis. So this drug has minimal risk of serious infections or infestations, and it is a very safe drug, and it is one of the very few drugs which have been discovered for patients suffering from generalized pustular psoriasis. Thank you.
Dr. Soumya, so
Yes,
this
sir.
was a systematic review of case reports, right?
Yes, sir.
And based on that, your conclusion is that it does not cause infections. Hello?
Yes, sir.
Yeah.
So my conclusion would be that it is a very well tolerated drug, since generalized pustular psoriasis is a very rare disease, but it is it has serious impact on the patients, as it causes painful pustules all over the body, and it hampers the lifestyle of the patient, and it can be life-threatening as well, because it leads to electrolyte imbalance.
Yes, Dr. Soumya, I got it. My
Yes,
question
sir.
is, how many papers were there in your analysis?
So very few trials have been done.
How
2 3
many?
multiple so 2 to 3 trials I have seen. They are
But you know,
randomized.
it was your review, no? You know how many, 2 or 3 trials? How many trials?
Sir, it is a very new innovation. It has been just discovered in 2020. So not much trials have been done. Whatever trials have been done, I have tried to systematic review according to that.
Yeah. So when you do a systematic review of trials, so how do you report the data? You report in a descriptive manner, or you make some forest plot, or do some synthesis of data or something like that?
So since very few studies have been done for this, so therefore I tried to make it more arithmetics to show its impact, because not much data have been there. So any graphical presentation was not so accurate, which I was getting. So I'm sorry if I did not do as it
No,
was
no,
required.
this was just a question. It was just a question. Thank you.
Yes, sir.
Okay, thank you, Soumya Singh. No question.
Thank you, ma'am.
Dr. Sajadullah.
Madam, I am there.
Yes, please start.
Good afternoon, everyone. Today I am going to present a case report on anti-tubercular therapy-induced cutaneous adverse drug reaction, and it is a case report. A 62-year-old female presented to the dermatology OPD with the complaints of red-colored lesions over the trunk and lesions in the oral cavity since 10 days. And actually, she was started for anti-tubercular therapy in view of diagnosed as a pulmonary tuberculosis. After the starting of therapy, after 2 weeks, she developed erosions. On examination, these were diffuse erythematous, branchable and maculopapular rash was present over the trunk, bilateral extremities. Palms and soles were also involved, and erosions with crusting on lips were also observed. And based on these findings, it was diagnosed as ATT-induced cutaneous adverse drug reaction. And to conclude, the maculopapular rash is the commonest area among all these ATT-induced reactions. And as these anti-tubercular drugs are limited in availability for first-line treatment, they should not be stopped if the ADRs are very minor, and they should be continued. Only if the ADR is severe, only the drug should be stopped. And re-challenge is the safest method to find out any other alternative regimen. Thank you.
Dr. Sajadullah.
Madam.
Yeah. I would like to ask, first you tell me what was the main conclusion of this study? What you concluded from this study, this case report?
I want to conclude that the reactions, they should not be stopped for minor reactions, and the drug should be stopped if the reactions are major only.
You mentioned it was ATT, first line, second line. It was not
Yes,
very
madam.
clear. The patient was on first line ATT or second line ATT?
First line ATT, madam. Combination of FDC combination of HRGD, madam.
Dr. Sadullah, I have only minor query. As you said that this is very common, so what was the novelty in reporting this case report? This is very common, no? You yourself mentioned that it happens in 50% of the individuals. So what was the novelty in this case report? That is my question. Hello, can you hear us, Dr. Sadullah?
Yes, sir. Yes.
Is there any novelty out of this case report?
Common only.
Anything new? Any new information which may help patient care? Okay, I think we can go for next case. Thank you. Thank you very much.
Is it audible?
Yes, please start.
Good afternoon, everyone. I am Dr. Shravan, pursuing my DM in Clinical Department of Clinical Pharmacology, JIPMA. Background of the study. So I am going to present a case report titled Lyell syndrome induced by phenytoin complicated by road traffic accident. So background of this report. So there are many case reports which the doctors should be vigilant because of the severe adverse drug reactions like thalidomide tragedy. So in this clinical case, a 17-year-old patient had a history of a road traffic accident followed by seizures. So he was administered injection phenytoin followed by tablet phenytoin for his complaints. And following the oral administration, he developed fever and bullous lesions all over the body with oropharyngeal ulcer and eye infection. He was found to have multiple vesicles over the chest region, abdomen, and extremities. On treatment, he was stopped tablet phenytoin in suspect of phenytoin-induced Lyell syndrome, and he was treated with pulse therapy of dexamethasone,
Can you hear some
azithromycin.
sound? Yeah, please summarize within 30 seconds. You were given only 1 minute to summarize the case. Can you summarize
Yes,
in 30 seconds? Yeah.
Yes, so actually, this is a case report of phenytoin-induced Lyell syndrome, which is complicated due to road traffic accident, and he was treated with levetiracetam for his seizure complaints. And the point to be noted is cyclosporin is also given, since both steroids they will facilitate the progress recovery of the disease. And to be borne in mind is we should also note about the genetic cause, because a genetic cause also increases the risk of Lyell syndrome. Thank you.
Okay, so this is a case report of phenytoin, which is a rare case report, right?
Yes,
So,
yes.
so you mentioned that it was complicated by the accident. How it was complicated by the
Yes.
accident? Can you explain in
No.
few words only? Yeah.
Yes, sir. Actually, road traffic accidents also increases the risk of seizures, sir. But already the patient is also having seizures, so that may be one of the reasons which could complicate. So to prevent that, you should be advised to preventive measures like wearing a helmet while driving, sir. Because in road traffic accidents, the risk is of seizures getting is very high. Hello. Yes, sir. Hello.
Yeah. Thank you, Dr. Shravan. No questions from my side. Next speaker, please.
Thank you.
Dr. Akhila Verma.
Am I audible, ma'am?
Yes.
Good afternoon, everyone. I'm Dr. Akhila, second year postgraduate from Siddhartha Medical College. So I'm going to present about a case report, which is an aceclofenac paracetamol-induced erythema multiforme. So this was reported in an 18-year-old boy who attended a dermatology OPD with complaints of rash over the face, trunk, and also both the limbs after taking the drug, which is a combination of aceclofenac and paracetamol for fever, which he took from local RMP. So he developed these lesions after a single administration of the drug, but later the drug was discontinued and it was diagnosed as erythema multiforme due to significant target lesions. And later he was treated and the patient started to recover. So I want to conclude that these non-steroidal anti-inflammatory drugs are prescribed widely and they are used over the counter by many people. So the public has to be educated about the serious adverse drug reactions that may occur due to simple drugs like aceclofenac and paracetamol, and they should be educated to report adverse drug reactions. Thank you, ma'am.
Dr. Akhila, I would
Yes,
like to
ma'am.
ask you how, what is the frequency of this type of reactions? How frequent this type of reaction occurs because of NSAIDs?
NSAIDs, this cutaneous adverse drug reactions are rare, ma'am,
Yeah.
but severe drug reactions are rare due to this NSAIDs.
You mean to
There-
say continuous monitoring is important even with NSAIDs,
Yeah.
which is used
Yes,
as
ma'am.
over-the-counter drug, right?
Yes,
Okay.
ma'am.
So next speaker, please, Dr. Velam.
Good afternoon, ma'am. Am I clear to everyone? Ma'am, am I audible? Hello, can you hear me?
Yes, yes. Please
Yeah.
start.
Thank you. I'm Dr. Alekia from Rangaraya Medical College, Andhra Pradesh. Now I'm going to present here about case report of paracetamol and mefenamic acid-induced Stevens-Johnson syndrome. I'm going to just summarize the case history. An 8-year-old girl present to our pediatric department complaining of rash on the upper extremity of the body. She has took the treatment for fever one day before that. She has took paracetamol and mefenamic acid. After taking the TARC syrup, within half an hour, the patient developed severe burning sensation and mild rash. And after 2 days, she got admitted to the hospital with confluent erythematous rash on the upper extremity of the body and oral mucosa, and hemorrhagic crust are also present over the lips. As the 30% of the body is involved, less than 30% involved, so we have diagnosed that to Stevens-Johnson syndrome. And according to the WHO causality, causality has been taken it as possible. And coming to the conclusion, physician should be more careful while prescribing the drugs, and even we need to check with the test dose and all while giving the prescription medications. Thank you.
Who you found in this case report, case study?
Ma'am?
Anything new? Because this is a very common, I guess, common
With the
area
paracetamol,
because
it is
of this
common,
drug, right?
ma'am.
So anything new or anything different you found? I'm just asking like that. Anything different or anything other than other studies you found anything new in this study, in your study?
Actually, there are only 56 skin reports have been reported with combination drug. Ma'am. And in that only 11 Stevens-Johnsons are reported. With only paracetamol, we can found many areas. With combination, we have only minimal areas.
Okay. Thank you. Next speaker, please.
Hello.
Yes.
Good
Dr.
afternoon,
Chitra.
ma'am.
Yeah.
Yes,
start.
I'm audible. Hello.
Yes, Dr. Chirag, please start your
Okay, okay. Ma'am, today, good afternoon, first off, and today I present a case report of the FTE, fixed drug eruption, caused by metoprolol. So, ma'am, it is a very rare adverse drug reaction because a metoprolol is widely used for the hypertensive as a hypertensive, but there is no such kind of reaction founded on VGSS itself. Only a 7 incidents of FTE due to metoprolol is reported till now, and there is no such case reports are published in the articles. So I have this report presented. A 48 years old male patient who is taken tablet metoprolol 25 mg twice a day. For fifth day, he developed a single skin lesion over the left hand with itching that was diagnosed as a FD by the skin department, and he was stopped the metoprolol and treated with the chlorpheniramine for 7 days, and there is no past history of similar reaction. And on that patient, that skin reaction happened, there is no other drug was started, and patient recovered after 2 days. So I concluded that such kind of rare fixed drug eruption, such kind of rare incidences commonly, reporting of such event is very necessary, and therefore the pharmacovigilance plays a role in the many hospitals as a AIIMS centers. So clinicians should
Thank
be
you, Dr.
aware
Chira.
of the presentation. Okay, sir. Thank you.
Yeah. So basically, why you think that it is because of metoprolol? It may be because of some other conditions.
Sorry, sir. I can't hear.
Hello, can you hear me
Hi,
now?
sir. Hi.
Yeah.
Yes.
So my question is, what makes you think that this condition, the drug eruptions, are because of metoprolol? It may be because of something else.
Sir, patient was not on any other treatments, so only a
So
metoprolol started in
so
that
do
week.
you think to have a eruption, right?
Yes, sir.
Have eruption, you have to have drug. Maybe something else, right? There may be some contact dermatitis kind of condition, or there may be something else, right? Why you think it is because of drugs
Maybe, sir.
only?
Yes, sir. Maybe happen, but the patient has a no such type of reaction in the past. There is a no past history for this kind of reaction, and patient is
That against goes in the favor of something else, right? Because the patient
Okay,
has
sir.
no history of such reaction. This drug is not known to cause such reaction. Though it should be reported, there is no doubt about that. The question is
Okay, sir.
about causality. Do you think the metoprolol causes this drug?
Sir, many hypertensives are causes such kind of reactions, in which diazepam, enalapril, such kind of reactions are presented with these drugs. But
Okay.
metoprolol
Thank
is
you.
only 2 or 3, sir. Okay, sir.
Thank you, Dr. Chifat.
Okay, sir. Thank you, sir.
Yeah, Dr. Neeraj, can you hear us?
Good afternoon, sir. Good afternoon, ma'am.
Yeah. Please summarize your case within 1 minute, okay?
Sir, the case report of a 12
Try to be brief. Try to
Yes,
as
sir.
brief as possible. Thank you.
Sure, sir. It's a case report of a 12-year-old child who was admitted to emergency on 4 September last year with history of unknown bite a day back. So a dose of ASP was given for the suspected snake bite, after which he developed articular rash, although he was given other supportive and concomitant medication. Now, the point of discussion that the ADR with ASV, that is anti-snake venom, was reported with WHO quality assessment scale of total, because
Chirag, your voice is not clear. Dr. Neeraj, your voice is not clear. Can you adjust your mic or something?
Yes, sir. Should I start again, sir?
Your voice is not clear. Yes.
Am I audible, sir, now?
Can you adjust your mic, or can you close to your mic?
Yes, sir.
Close to your mic.
Is it audible now? Is it audible? Hello? 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 Hello, am I audible, sir? Hello?
Hello, can you hear us, Dr. Neeraj?
Yes, sir. Yes, sir. I can hear, sir. Am I audible now?
Yeah, you are audible now. Please summarize within 30 seconds. Okay?
Yes, sir. So it's the case of a 12-year-old child who admitted to emergency with a history of unknown bite on a day back. This was a case of last year, 4 September 22, where he was admitted. Now, a dose of ASV was given for the suspected snake bite, after which he developed a articular rash. Although he was given other supportive and concomitant medications. Now, the point of discussion for this case report that ADR with ASV was reported with the WHO quality assessment scale of probable. Now, this was one of the less frequent incidents where the life-threatening, life-saving ASV has led to an anaphylactic reaction. Now, just I want to conclude my case report with and presentation, and also as recommendation as a pharmacologist, that the test dose of ASV should be given prior to full dose of ASV. So it's our responsibility also.
Dr. Neeraj, can I? Yeah, we understood your case report. The question
Yes,
is,
sir. Yes, sir.
in the methods you mentioned insect bite, right?
Yes, sir. Yes, sir. Yes, sir. Hello.
So insect bite.
Yes, sir. Yes.
Hello, can you?
Yes, I can hear you, sir.
Did you understand my question?
Yes, sir. Please repeat, sir.
Question is, the patient came with the history of insect bite, right?
Yes, sir.
And you mentioned that anti-snake venom was given to this patient.
Yes, sir.
So how that happens?
So because patient complained with a right hand swelling, also with pain in abdomen, and also with a history of drowsiness for 1 day. So that's why, and also when his blood was taken,
And normally when ASV is given, I think they test it for allergy, right?
Yes,
They
sir,
test it
yes,
for
sir.
allergy before giving it to the
Yes, sir,
patient.
yes, sir.
Was
Yes,
it
sir.
done in this case or it was not done?
No, so it was not done as per my knowledge. It was said that the blood was taken from the patient and it was kept for observation.
Okay,
And
okay. Thank you very
when
much.
it was thought it was unclotted, it means that something has hyperfibrinogen
Thank you.
has happened. So it could be a venom-induced consumption pattern. So that's why this very important test has been done to start or repeat the ASP in case of, or to also initiate the ASP in case of snake bite. So that's why it is very important clotting test which can be done on the bedside to understand whether it's a
Thank you.
snake bite or it's because of a snake bite. So thank you very much, sir.
Hello, am I audible?
Yeah.
Good afternoon. I'm Dr. Mansi. I'm presenting a case series on propofol-induced fever. Propofol, an intravenous anesthetic, though short-acting and safe, is known to cause ADR such as fever, hypotension, and so on. Over 7 years, in our setup, we have had 3 mass ADRs consisting total 18 pediatric patients posted for MRI who were administered propofol among other drugs. All patients presented with fever along with other symptoms such as chills, convulsions, and so on. They were administered injection pheneramine, hydrocortisone, and piptaz. 17 patients recovered while 1 had a fatal outcome. All the cases were classified as serious and causality was possible. A propofol vial from the same batch was sent for culture, but no growth was seen in that. Fever due to propofol can be due to hypersensitivity or contamination. The medium of soybean oil, egg, and glycerol make it a suitable medium for bacterial growth. Measures such as following strict aseptic conditions, using a vial within 4 hours of opening, not continuing an infusion beyond 12 hours, ensuring single use of vials, all these measures have been taken up in our setup and no such further outbreaks have ever occurred. Certain countries also use additives such as EDTA for preventing the contamination. That's all about my case series. Thank you.
Okay, Dr. Mansi. So what do you think? What was the reason for this outbreak of the propofol-induced fever?
So, sir, in this, despite the culture being negative, we are still suspecting that it could be due to bacterial contamination because they did not send the vial from which the drug was administered. They sent another vial from the same batch, so we cannot completely rule out bacterial contamination. All the patients were given antibiotics and they showed a recovery. So I would still go in favor of that.
Okay, thank you. Thank you very much, doctor.
Thank you.
Dr. Imani? Can you hear us?
Yes, sir. Good
Please,
afternoon, sir. Yes,
yeah,
sir.
please summarize your case report within 1 minute.
Yes, sir. It was a case of a female, that is Harjeet Kaur, 37 years old. She had some febrile illness for 7 days. After that, she had some generalized weakness, sad moods, decreased appetite, and all, for which the doctor prescribed tablet of fluoxetine 20 mg HS. She taken it for 2 months. After taking fluoxetine, she had a pain abdomen which was radiating to back, but she is a non-case of renal stones. So doctor advised her for USG ultrasound whole abdomen for ruling out the size of the stone. But accidentally, the doctor found there is a marked hepatomegaly in the ultrasound, for which other investigations were also done, but on examination and asking the previous history.
Okay,
And
Dr. Himani, yeah.
Yes, sir.
So straight away, we can go to the questions.
Yes,
can
sir.
we report the name of the patient in a case report?
No.
You mentioned Harjeet Kaur. Is it right way to, like, I think?
Okay, sorry,
it
sir.
may have ethical
Yes, sir.
implication, no?
Yes, sir. Sure, sir. Sorry, sir.
And
I will.
next question is, why do you think it was because of fluoxetine? The patient were having fever and maybe some infection.
Yes, sir. CBC and other investigations were also be investigated for her, but no another such thing was found for which was ruling out the cause of hepatomegaly.
What was the causality assessment of this case?
Ma'am, it can be possible, because after which fluoxetine was not stopped for the patient for that. So
Was she was some on other drug?
no, ma'am. Just paracetamol was given for febrile illness for his for her fever. No such other medication was there.
Did you took a diet history of this patient?
No, diet history was not taken.
Okay. Next, Dr. Bhavna.
Good evening, judges and my esteemed delegates. Here I present a case series, hypersensitivity reactions to lignocaine hydrochloride. Lignocaine hydrochloride is a preferred local anesthetic agent for use in surgical procedures, rarely causing exaggerated immunological response, that is the triple response of wheal, flare, and redness. 3 cases were reported from Ops and Gynae department having given 0.5% lignocaine hydrochloride intradermally on the ventral aspect of forearm. All 3 reported signs of triple response, that is wheal, flare, and redness after a few minutes. The patient's hemodynamic conditions were assessed and the patient was found to be stable. There was no history of any sort of allergic disease or drug allergy. Therefore, we just want to stress the importance of this hypersensitivity testing or antigen sensitivity testing in patients who are being injected this lignocaine. So the practitioners should be made aware that allergic reaction, though rare, can lead to mortality and morbidity. So a proper diagnosis and management should be planned in case such cases are reported from any surgical department. Or
so, Dr. Bhavna, what was the causality assessment for this?
Probable, sir, but we are in doubt of possible because it was xylocaine which contained parabens also, methyl parabens, which also is a reason for hypersensitivity reaction as per reports. So although we are saying probable because it was in a xylocaine, lignocaine with methyl paraben, but both the compounds are known to cause hypersensitivity reaction. So it can border on possible also because there is another agent, although the temporal relationship, time relationship is there. No other drugs were concomitantly given to such patient, and all were what pre-op assessment was done, and all were normal and undergoing some LSC.
Thank you very much, Dr. Bhavna. Thank you.
Thank you, sir.
Next one, please.
Good afternoon.
Yeah.
So, am I audible to everyone?
Yeah, please start and be fast.
Yes. Yes, ma'am. Good afternoon, one and all. And I present here the case series of rare adverse drug reaction, supraventricular tachycardia due to dolutegravir. The drug can cause ECG changes in the form of narrow QRS interval and tachycardia, which might be secondary to myocarditis. Here are 3 cases of SVT which came to a hospital with chief complaints of retrosternal pain, giddiness, and palpitation. All of them were diagnosed cases of retroviral disease having few comorbid conditions. Diagnosis of drug-induced SVT was done and the suspected drug was withheld. We did the ARIA assessment and the reaction was known to be unpreventable and severity of ARIA was moderate. Causality was evaluated to be possible as disease pathology itself can contribute towards myocarditis development. However, mechanism of dolutegravir causing myocarditis yet remains unclear. Concluding my presentation, I'd like to say as dolutegravir is a first-line agent, it raises a question for its further use. Thank you.
Hello, Dr. Bakul, who is Dr. Bakul Naik, no?
Yes.
Yeah.
Yes, yes.
So, Dr. Naik, my question is, have you gone through the literature? How many such reports are there where the dolutegravir was linked with the...
So, only 2 case reports I found out, sir. So, I have mentioned the references also. Only 1 case report had mentioned 2 cases and 1 report had mentioned 1 case. So, in total, only 3 case reports have been presented till now.
Yeah, but reference, I think it is not about, references are not from case report. If I'm not, the first reference is not from case report, right?
Yes, sir.
It is from trial, no? The first reference is from trial, not from case report.
Yes, but second reference, sir, definitely the Mahalab Guri reference that I've given also in the objective, it mentions about 2 case reports.
So there were 2 patients where the multi actually in all the patients other drugs were also there, right? Like in patient one.
But in so patient 1 and patient 3, only this TLD regimen that was going on. But yes, in patient 2, this tuberculosis regimen was also going along with our drugs, our HIV drugs.
Okay. Thank you very much.
Thank you so much, sir.
Dr. Saida. Dr. Saida, can you hear us?
Yes, sir.
Yeah. Please summarize in 1 minute, okay?
Yes, sir. Good afternoon to all my professors. My topic is poster presentation to evaluate the safety intravenous iron ferric carboxymaltose in severe iron deficiency anemia in a tertiary care hospital. Introduction is nutritional iron deficiency anemia. Nutritional iron deficiency anemia is the most common nutritional disorder in both developed and developing countries. FCM is given in IDA and patients who are intolerant to oral iron preparation or require a quick buildup of iron stores. To estimate my aim and objective is to estimate the clinical safety of FCM in view of adverse effects and therapeutic safety in severe iron deficiency anemia patients. Inclusion criteria I have taken: hemoglobin patient more than 6 grams per deciliter and less than 10 grams, and patient taking FCM, pregnant woman 16 weeks to 36 weeks, as we cannot give in first trimester because it is teratogenic, and reproductive age woman group with heavy menstruation. My exclusion criteria is patient suffering from iron deficiency, severe iron deficiency anemia, causes other than pregnancy and heavy menstruation. It's a method and materials and methods. It is an open label observational study. Duration is February 2023 to April 2023. Total of 25 patients I have included in the study. And after exclusion, 10 pregnant women, what I have observed is 10 pregnant women attending from the antenatal checkups between.
Dr. Saida?
Yes, ma'am.
Just describe your conclusion.
See, my conclusion is, ma'am, FCM is I have to see the safety profile of FCM.
So what was found in your study?
FCM is a safe intravenous agent in pregnancy and reproductive age group. Regarding the tolerability of the safety profile.
For safety profile, how many cases you found during that period?
Ma'am, I have done the study in 25 patients. Safety profile adverse reactions are mainly mild to moderate reactions were observed. That moderate reactions are shortness of breath is observed in 1 patient, which can be reduced by infusion, slowing the infusion rate. And mild reactions like skin discoloration have been observed in a number of patients. We can reduce this skin discoloration or extravasation of fluids by doing flushing before withdrawal of the needle.
Okay, thank you. Thank you. Next speaker, please, Dr. Suraj. Dr. Suraj. Dr. Suraj, are you there? Dr. Suraj, are you there, or shall we move to the next speaker? Next. So we'll move on to next speaker, Dr. Smriti.
Hello.
Good afternoon, ma'am. Good afternoon. Okay, Dr. Suraj, you are there?
Yeah, yes, ma'am. Yes, ma'am.
Please start and be quick.
Yeah. Okay. My study title was Adverse Reaction Monitoring following COVID-19 immunization among the healthcare workers. And since it was novel, considering the pandemic, we thought there was a dearth in research studies about the adverse event following immunization. So our objective was to determine the incidence and the types of adverse event following COVID-19 immunization. And it was a prospective single-centered observational study, which was conducted in healthcare workers. Ma'am, the study participants were interviewed at the vaccination site, and the WhatsApp group was created on daily basis. However, a Google form link was sent after 24 hours of vaccination to capture the demographic, clinical, and adverse effect profile. Out of the total participants, that is 1,045, 64% responded to the Google form, of which majority were the medical students, attributing to 52%, and all the AEFI that were reported were minor in nature. And we could found that 4 AEFI were classified as immunization anxiety related reaction, because within half an hour of vaccination, there were 4 cases wherein they were dizzy, and the AEF management team was there, which we didn't require the hospitalization. Hence, it was declared as immunization anxiety
Dr.
related
Suraj,
reaction.
Dr. Suraj, the question is, did you find that adverse events were more in females as compared to males? In your
Females, no, sir, not in our
did you
study.
went for this kind of analysis in your study?
Yes, no, sir, exactly. We went for the age group. Relatively younger population, it was more in our setup. But we could have also gone for the gender, but there was no significant association. That was our secondary objective. Yeah, I could relate one study from the PGH Chandigarh. Yes, there was a significant among the females, sir.
In majority of the studies done for vaccine adverse event, it was found that the frequency is more in the female as compared to male, and there is a reason for that. So in your study, it was not observed, right?
Yes, sir. Yes, sir. Yes, sir.
Okay.
Sir, I'm not sure about the reason. Probably because of the.
I just wanted to know whether you found this or not in your study.
No, sir. No, sir. No, in our study. No, sir.
Okay. Okay. And was there any relationship between the person who has COVID and got adverse event after vaccine, or people having no history of COVID and have the adverse events?
Sir, there was a gap of at least 4 to 6 weeks. So that's why we couldn't attribute it, whether it was because of the COVID-19 and the vaccination. However, we made sure that there was a gap which was maintained, and therefore it was mostly related to the immunization itself, sir.
Okay, thank you. Thank you very much.
Thank you, sir. Thank you.
Good afternoon.
Yeah, Dr. Smriti.
Yes, good afternoon, respected teachers. I'm Dr. Smriti. My topic of poster is safety profile of drug prescribed in COVID, a pharmacovigilance perspective. Background: as COVID-19 pandemic highlighted relevance of pharmacovigilance and proper risk communication during public health emergency, as there was accelerated approval of the drug during the pandemic. Aims and objective: to elucidate the recent adverse drug event associated with the 8 potential drugs commonly used in COVID-19 patients. Methodology: after thorough literature search, studies on adverse events suspected to be induced by anti-COVID drug using keywords adverse drug reaction, adverse effect through search engines including PubMed, Cochrane. Various drug repurposed in COVID-19 were compiled and detailed analysis was done. Now result: the anti-COVID drug in RCT design, dexamethasone, was found to cause hyperglycemia, GIT, hemorrhage. Favipiravir, it causes diarrhea, nausea, vomiting. Lopinavir, ritonavir causes diarrhea, loss of appetite. Ivermectin was found to cause headache, dizziness. Tocilizumab causes hepatic dysfunction. Remdesivir causes nausea. And in case report, hydroxychloroquine used to cause QT interval prolongation.
Dr. Chawla, just a quick question, Mike. How many studies you?
Sir, I've seen 5-6 studies. As
5 studies based on 4 study, you can conclude something.
Yes, sir.
There are many studies related to COVID, right? There are multiple clinical trials.
Yes, sir. Yes, sir.
You mentioned. So, do you think based on 4 or 5 study, you can conclude about the adverse effect of any intervention?
Sir, actually, there was after, like in case of hydroxychloroquine, if the drug was stopped or if other measure was done, the causality assessment was improbable in articles which I have studied. You are right, sir, since there are many studies only on the basis
now,
of
like in the case of remdesivir, the most common adverse effect is renal problem, right? Which you have not mentioned, right?
Sir, I have mentioned hypokalemia. Yes, sir, renal problem is the main.
Is a main, right? But then it is not there. So it may be because of the very few studies there in your analysis. That may be the reason for that.
Okay. Okay. Thank you, sir, for correction.
Thank you. Thank you very much.
Hello.
Yes, Doctor.
Hello. 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 Hello.
Hello. Hello. Hello. Am I audible?
Hello.
Hello.
Hello, Dr. Jyoti.
Yes, ma'am.
You can start now.
Okay, ma'am. So my topic was training program on patient safety and pharmacovigilance for nurses. So nurses play an important role in ADR reporting because they are very much in close contact with the patients for a long duration of time. So the aim of our study was to create awareness among nursing professionals regarding detection and reporting of ADRs. So we incorporated 90 nurses and we have given training, educational training to them in 3 sessions. 30 nurses in each session. So before the conduct of the training program, we have given them a pre-test questionnaire consisting of 20 questions regarding various aspects of pharmacovigilance, what they know. And after the training session, we have given them a post-test questionnaire consisting of the same questions, and we noted down their results. So overall, we have seen that after the educational training program, so there was a significant improvement in the knowledge and positive attitude towards the pharmacovigilance and reporting of ADRs among the nursing professionals. So we must encourage them. And the most common reason why they don't report ADRs, we could find out from our study, was that because they reported that they have lack of time to report ADRs because of the increased patient burden. And second thing, they reported that they don't get any remuneration for the reporting of ADRs. So that's why they generally don't report the ADRs. So we must encourage them to contribute in collection and reporting of ADRs to improve the overall patient safety.
Dr. Jyoti, can you hear me?
Yes, sir.
Yeah. So in this study, there was a pre and post, assessment based, and you.
Hello. Hello. Hello.
Hello.
Hello. Yes, sir.
Yeah. So as per your study, the training increases the knowledge and attitude component of the questionnaire.
Yes, sir.
Yeah. So don't you think that when a questionnaire is administered,
yes, sir,
before the training, and then same questionnaire administered after the training, so
yes,
there will be some bias, call it recall bias or something like that, where
yes, sir, bias is always there, but after the study we have seen that because we have increased number of ADRs from these nursing participants, which bias is definitely there. But overall, we could find out that we have created awareness among them, and we have encouraged them further to report the ADRs, because many of them, they were not knowing only what is ADR. I mean, they were identifying these signs and symptoms which they think because of some other reason. So we have just given knowledge about them, what are the ADRs, what are the different aspects of pharmacovigilance. So they have just more brushed up knowledge, and so that they can further report them better. Hello.
Audible?
Hello.
Am I audible?
Yes, ma'am. Yes, ma'am.
Okay, you said there is an increase in the number of ADRs. So may I know how much percentage of increase was there?
Ma'am, approximately 30 to 40%, because initially our postgraduates and our pharmacovigilance associate, they were only the persons who were getting the ADRs. But now these nurses, they have taken our phone numbers, the number of associates. So we have got many, approximately 30 to 40% increase in number of ADRs from these specific people.
One more thing you said, ki nurses said about remuneration. They are not getting any
Yes, ma'am.
remuneration regarding ADR reporting.
Yes.
So what suggestions could you give them, or what how you can counsel them for remuneration?
We can just tell them that it is their moral responsibility, because they are the healthcare professionals. So it is their moral duty to report every aspect of the thing, whatever they are getting feedback from the patients. So remuneration, we just can tell them that it is a part of duty, and they should do it. Hello,
Dr. Madhumita?
Hello.
Yeah, Dr.
Hello.
Madhumita.
Am I audible, ma'am?
Yes, please start.
Good afternoon, judges. The topic of my e-poster presentation is knowledge, attitude, and practice of general public about drug safety. Drug safety is a critical concern for public health, as it directly impacts the well-being of patients who are on medication to treat their illness. While drugs can offer many benefits, they also come with risk and side effects too. Therefore, this cross-sectional study was conducted on 609 drug consumers of different age groups. Results were 94% believe that drugs can have both good as well as bad effects. 3% were aware about ADR forms. Only 1% were aware about toll-free helpline number. 83% believe that it is the duty of everyone to report ADR. 86% said that they would not consume the drugs causing side effects. 67% said that they would first stop the drug before consulting the physician. Discussion as the result from our study indicated that education and public awareness is important in promoting safe medical practices. Many patients were not aware about the concept of ADR and pharmacovigilance. Many patients were not able to recollect the side effect of medication, and many were not aware about the nearby pharmacovigilance center as well as the toll-free helpline number.
Dr. Madhumita? Yeah.
Yes, sir.
Yeah. My question is, you wrote there that it was a validated questionnaire, right?
Yes, sir.
So do you think it was validated in the Indian population, or it was validated outside?
Sir, it was validated in the Indian population, sir.
Which questionnaire you are talking about?
Sir, questionnaire, I had taken the questionnaire from the articles of public awareness and perception about drug safety in patients residing in Western.
First reference, no? First reference.
Yes, sir. Yes, sir. First reference.
So have you
Munshi
gone through the first? Yeah. So did they use validated questionnaire, or they used some other questionnaire from some other
Sir, they had used a validated questionnaire, sir, and so they had given Cronbach alpha about 0.75, and sir, ethical committee clearance was also there. So
okay, and you in your discussion you mentioned that results of our study indicates that education and public awareness is important. So did you compare the awareness of these knowledge, attitude, and practice of these people based on education level?
no, sir, because in my hospital area, I had taken it from the medicine OPD, sir. I'm going there for thesis work twice a week. Therefore, I have gathered.
No, as per your discussion, no, that you mentioned
Yes,
that
sir.
education and public awareness is important in promoting safe and medical practice.
Yes, sir. Yes, sir.
I thought you may have like did some analysis based on education level.
No,
just
sir. We
looking
had taken random general public.
No problem.
Thank you.
Okay, thank you very much.
Thank you, sir.
Jindlori. Dr. Jindlori?
Yes, sir.
Yeah. Please summarize your poster within 1 minute, okay?
Yes, sir. Yes, sir. A very good afternoon to all. I am presenting analysis of cutaneous adverse drug reactions reported at ADR Monitoring Center according to demographic profile, morphological pattern, causative drugs, severity, and outcome. It was a retrospective data analysis. Out of 176 ADR reported, 78 were cutaneous ADR among 44 males and 34 females. Common age category which was affected was 19 to 40 years. The most common clinical presentation were maculopapular rash, followed by itching, urticaria, acneiform eruption, and fixed drug eruption. The most common drug category was antimicrobials. Among antimicrobials, most commonly reported cutaneous ADR is due to beta-lactam antibiotics like ceftriaxone, piptaz, and then amphotericin B. The second drug category includes NSAIDs. Regarding severity, among reported cutaneous ADR, 51% were mild, 45% were moderate, whereas 4% belongs to severe category. So, and 5.13% were belongs to probable, and 94.87% belongs to possible category when analyzed according to WHO UMC scale. Thank you so much.
Okay, so what is the take-home message out of this study? How the finding of this study is going may helpful to the patient care?
Yeah, since antimicrobials were the most common drug category which are responsible for cutaneous ADR. So while prescribing antimicrobials, you should be cautious and it should be rationally prescribed. If it is needed, then only it should be prescribed because it has a more chances of developing ADR and especially cutaneous ADR.
Dr. Aparna?
Yes, sir.
Yeah,
Am I audible, sir?
Yeah, please present within 1 minute, okay?
Okay, sir. My study title is Study on Adverse Drug Reactions from Rural Tertiary Care Teaching Hospital. It is an observational descriptive study. Coming to the findings, study was conducted over 1 year and total 140 areas were reported to the ADR monitoring center. Among them, females are mostly areas were reported mostly from females, constituting 61.42%, in an age group of 19 to 60 years, constituting 85%. Most common route of administration being oral. And coming to the departments, psychiatry is the majority areas reported, followed by the dermatology, pulmonology, and ART. And most common manifestation being the skin rashes, followed by sedative and drowsiness. And the least common were buffalo hump neck. Based on the causality, WHO UMC causality scale, among 140 areas, 82.8% were graded as probable, and based on the severity scale, modified Hartwig and Siegel scale, 1.4% areas were severe. Our present study findings have certain limitations in the form of incompleteness of ADR forms, which can be overcome by re-emphasizing on ADR reporting and its importance.
Yeah.
Thank you.
So question is, why ADRs were more reported in the females as compared to males?
Means among the areas, adverse drug reactions are most in females compared to males on the analysis.
So what can be reasons for that? Do you think in the case of females, it was easy to report, or there is something related with the physiology or some phenomenon where females are having more ADR as compared to male?
No idea, sir.
Okay. Have you gone through literature? Did you try to find reason for that?
Yes, sir. In every in my reference, there's a demographic status.
Okay.
I have been considering that, sir.
So there, at this place, female patients are more as compared to male.
Yes, sir. Means maybe one of the reason males having more androgens, which are which may be the cause. Sir. Hello. Hello.
Am I audible?
Yes, ma'am.
You mentioned about causality assessment that most cases are in the probable group. So
Yes, ma'am.
could you explain the reason, or could you explain it?
Yes, ma'am. Most of the ADAs means ADAs may be mild, moderate, severe. So in our tertiary setup, most of them were graded as a probable. Means
What are the criteria for categorizing it as probable?
Means
it is based upon WHO UMC scale, I guess.
Yes, ma'am. Yes, ma'am.
So how you classify possible and probable there? What are
Means
the
any event,
criteria?
any event with reasonable time relationship can be considered as probable, ma'am. And it may be not unlikely to the, it is unlikely to the disease or other drugs. And rechallenge is not satisfactorily seen in probable. Whereas in certain means it is there will be a plausible time relationship to the drug intake and can be explained by, cannot be explained by disease or other drugs. Response to withdrawal will be plausible.
Okay, next speaker.
Thank you.
Am I audible?
Yes, please start.
Good afternoon, ma'am. Myself, Shautadusha Mukherjee from Department of Pharmacology, School of Tropical Medicine, Kolkata. I'm here to present my topic, that is health-related quality of life and its determinants among patients experiencing adverse drug reactions. Addressing the dearth of research in this area, we conducted this study to estimate the HRQOL indices among the inpatients experiencing ADRs in upper tertiary care and further explore the factors that negatively impact the HRQOL. So a hospital-based single-arm prospective 3-year study was conducted where we included all the consenting patients either admitted with a suspected ADR or those who were encountering ADR during the hospital stay. So for all the cases, we took up the basic demographic, the ADR details, and did the pharmacovigilance workup. The HRQL was assessed using the WHO-QL breadth and EQ5D at baseline and discharge and on follow. So as a result of this study, we included 519 cases, while 61.5% of the cases were admitted due to an ADR, 38.5% were encountering ADR during the hospital stay. We found 1.4 times more female preponderance in the study population. We had majority of the type B reactions, majority with the probable grade in case of the causality, and moderate in terms of severity, and mostly were non-preventable. Assessing for the EuroQL 5D, there were 5 domains of mobility, self-care, usual activities, pain, discomfort, and anxiety. And all the domains showed of moderate grade at baseline, which was almost normal, that is meant to the normalcy by the discharge and the follow-up phase. EQ-VAS it is another part of EQ5D, that is a 100 scaled self-rater scale in which the baseline scoring was 72, which increased with the time frame at discharge and follow-up. We also went for the WHO-QL breadth, which contains 4 main domains of physical, psychological, social, and environmental health. And for all the domains, the scores gradually increased from the baseline at the discharge and the follow-up. We found these 2 HRQL HRQL indices for the ADR severity as well as ADR preventability. We did not find any sort of striking difference for the ADR preventability, but for the ADR severity, the severe ADRs were much more in the lower level, the lower indices at the baseline, which gradually increased over the time frame. We conducted logistic regression analysis for the predictors of lower HRQL, where we fitted age, gender, ADR severity, preventability, geographic stay, and educational status. ADR severity was the strongest predictor for the lower HRQL, considering all the domains, while the patients with low education as well as higher age were also reported with lower HRQL scores.
Dr. Mukherjee?
So to conclude,
yeah, Dr.
Yes,
Mukherjee, what do you think? What can be the implication of these data?
So as an implication of this data, as we find that from the predictor model, that the low education as well as the higher age group, for both the cases, the prescriber should be very much aware, and they should be counseling regarding the adverse drug events, and there should be also early detection. So the ADR severity must be known to the patient while the medications are being given, such that to increase the awareness among the those who are being affected with the ADR.
Yeah, but when a patient come to hospital, right, its quality of life is going to decrease. That we all know, right?
Right, sir.
So whether patient is coming for a disease or for any adverse event, things
Yes,
are
sir.
going to be same, right?
So for the severe adverse events, the quality of life strikingly varies from those with the minor ADRs and those with the severe ADRs. So that is an important finding of this study, that the ADR, the severity and the each and every indices of the quality of health related quality of life, whether it's a physical or a psychological or the environmental aspect,
Thank you very
everything
much, Dr.
varies.
Mukherjee.
Thank you, sir.
Hello, sir. Am I audible?
Yeah, Dr. Keshav.
Okay, sir.
Can you hear us?
Yes, sir. I can hear you.
Please summarize within 1 minute. Thank you.
Okay, sir. A warm good afternoon, one and all. Today, I'm going to talk on the topic, excipients, are they safe? A review on case series of cutaneous adverse drug reactions. And what are excipients? Excipients are substances other than the active pharmaceutical ingredients present in a finished pharmaceutical drug formulation. And the aim of my study is to compile the knowledge related to the excipients and what need to be done if a drug is inevitable for a patient but presented with adverse drug reactions due to excipients. Here are two cases, one from Indian population and case two from a foreign population. And in case one, the patient was pulmonary tuberculosis positive, and he was taking FDC of ATT, and he developed adverse reactions, and later he was re-challenged with individual drugs for which he was compliant and completed the ATT course with individual drugs. In case two, the patient was autism spectrum disorder. He was on risperidone. On changing the brand, the patient developed adverse drug reaction and re-challenged with the old brand. He could continue the treatment with the old brand. And the takeaway points are that excipients, though are ideally supposed to be inert, but not practically, they often cause ADRs, and we think that it may be because of the active substance of the drug, and we change the main drug. And this results, the idea of this is good for the practitioners because an advantage of using the most effective drug can be made benefit for the patient. Thank you, sir.
Dr. Keshav, can you summarize what you have presented, because I could not get the. I mean, there are two cases which you are presenting, right?
Yes, sir. One case is that the patient was on FDC for ATT drug.
Yeah.
And the patient developed ADR.
In second case, the brand was changed, right?
The brand was changed. And the thing is that on changing the brand, the excipients present in the drug has changed, and that doesn't cause any ADRs. So the patient could complete the treatment with old brand itself. In the first one, actually, the patient was on FDC, and the excipients present in the FDC caused the adverse reactions, but the excipients present in the individual drugs didn't cause any adverse reactions, so that the patient could complete the course with individual drugs. I think in our presentation VP5,
can you
Yes, sir. So in VP5 presentation, I think Dr. Sayyid Abdullah has also presented a similar case. I think that was also a case of excipient actually, because excipients in FDC is causing the adverse reaction rather than the active drug component itself.
Have you gone through some other studies where this issue is explored with a larger sample size or something like that?
No, sir. No, sir. Actually, this is very rare in literature. I actually think that it's also a rarity in among practitioners. Also, they are also not having a good idea of this. See, in our presentation itself, it has popped up that the VP5, the presentation was also actually maybe a case of excipient. Okay. So I just want to summarize, and this gives an idea. I want to give totally an idea of this excipients and causing cutaneous adverse drug reactions.
Thank you. Thank you very much.
Okay. Thank you, sir.
Audible?
Dr. Manvir Singh, can you hear us?
Yes. Yes. Am I audible, sir?
Please summarize within 1 minute, okay?
Yes. Very pleasant afternoon, everyone. I'm Manvir, MBBS intern at AIIMS Rishikesh, presenting a cross-sectional study of 103 patients to assess the hypothalamus pituitary adrenal axis suppression with inappropriate use of steroids in recalcitrant dermatophytosis. My main aim of the study was to determine the adverse effect profile with inappropriate steroid use and its effect on H-axis suppression in patients of recalcitrant dermatophytosis. The main results which I found was 60% were males, and the mean duration of steroid abuse was 17.78 months. The mean age was 37 years. Among 103 patients, 49% used only topical steroids, 4% used only oral, had oral intake, and 48% patients used both topical and oral steroids. When we looked at the serum cortisol levels, the 8 to 9 a.m. morning serum cortisol levels were investigated. About 44 subjects out of 103 had decreased serum cortisol, and only 6 had elevated, with 53 patients having normal serum cortisol levels. The mean serum cortisol levels were in the decreased group was 1.29 microgram per dl. The most steroids used among the topicals was clobetasol, and in oral was prednisolone, followed by dexamethasone. We also looked for the adverse effects. About 62% patients had erythema, followed by central obesity in 46%, moon phases, striae, and buffalo hump. When we looked at the steroid use pattern in patient having depressed serum cortisol, about 76% patients used both topical and oral steroids. The main reason we can find out is that the superphysiological doses of exogenous corticosteroid cause HPXA suppression, which decrease the CRH synthesis and thereby inhibiting the adrenocorticotropic hormone from the pituitary. So concluding my study, a significant proportion of the patient had below normal serum cortisol levels due to steroid abuse, which is suggestive of HPXA suppression. Thank you.
Okay, so why you are saying that this is steroid abuse?
So mainly our inclusion criteria was the patients with recalcitrant dermatophytosis. Recalcitrant dermatophytosis is recurrence, relapse, or reinfection of skin infection for greater than 6 months.
Okay. No, why we are saying it is abuse? Why you are saying it's the steroid abuse?
So mainly in skin infections like scabies, tinea, steroids are not indicated. So if the patient is having long-term dermatophytosis, there is a chance that the patient is using steroids. And upon inquiring, also we found that the patient was using steroids.
Okay.
Hello.
Yeah, Dr. Monica Verma.
Thank you.
Hello. Who is Dr. Monica is presenting? Hello. Can you hear us? Hello. Hello.
Hello. Hello.
Yeah, Dr. Monica. Is this
Sir,
Dr.
am I audible?
Yes,
Yes, sir. Am I audible?
Yes, please go ahead with, please present within 1 minute. Okay.
Yes, sir. Good evening, respected judges. My topic for the presentation is adverse drug reactions associated with use of sulfasalazine in arthritis patient, a pharmacovigilance overview, which I will be summarizing. In March 2023, IPC issued a safety alert regarding sulfasalazine that it can lead to some visual impairment. So our aim and objective was to determine the different areas and assess the frequency, which we did by scrutinizing the ADR from retrospective 3 years, in which we found that one ADR of transient blurred vision was also received by our area monitoring center, which was followed by other ADRs like DRESS syndrome, hepatotoxicity, hypersensitivity reactions being the most common. And this pattern of ADR was similar to a study done by Tanakia et al. So in conclusion, I would like to say that this is just a maiden pharmacovigilance study, just an initial study which will provide in future the data regarding the prescription of this particular medicine, and extensive pharmacovigilance can be a boon in coming time if used in a corrective way. Thank you. That's all from my side.
Anything new you found in the study?
Ma'am, we just carried out this study because a safety alert was issued regarding sulfasalazine. So we wanted to explore the ADR pattern in our ADR monitoring center. And this can, in conclusion, as I said, that this can be a tool. Pharmacovigilance can act as a tool to carry out rational pharmacotherapeutics, ma'am.
Okay. Next speaker, sir. Next speaker, please.
Ma'am.
Dr. Aditi.
Yes, ma'am. I'm Dr. Aditi Bhandari. and I'm presenting knowledge, attitude, and practice of material vigilance among postgraduate medical students. The aims and objectives of my study were to evaluate the knowledge, assess attitude, and to note the practice towards material vigilance and ADR reporting among PG medical students. It was a cross-sectional questionnaire-based study done among postgraduate students of a tertiary care government teaching institute in southern Rajasthan. All PG students were included, and only those who were not willing to be a part of the study were excluded. A pre-validated questionnaire comprising of 18 questions was circulated among the students, and it was filled using Google Forms. There were no conflicts of interest, and the IEC approval was taken in advance. Out of the 110 participants, 83% knew about material vigilance, 64% have been trained about it, while 77% have a positive attitude for reporting of its ADRs. However, only 60.6% practice reporting of ADRs caused by these devices. Thus, to conclude, most PG students are aware of material vigilance and know about what should be done. However, their attitude is inert, and regular practice of reporting needs improvement. Similar results were seen in studies from foreign countries. Educational interventional programs should be done to promote material vigilance and ADR reporting in regular practice. And it should be a part of the UG curriculum so that the students are familiar to the concept. Thank you.
Dr. Aditi?
Yes, sir.
Yeah.
Sir?
Are of which specialty?
Sir?
The PG student, which were the subject of this study,
Yes, sir.
were of pharmacology specialty or
No,
from
sir.
some other branches?
All PG students of the institute, all PG medical students.
And there were 83% awareness about the material vigilance.
So 83% had knowledge, while 64% said they have attended some CME or training about it, and 77% had a positive attitude towards it. We had taken a questionnaire of 18 questions. Since there was lack of space and time here, we couldn't enumerate all the questions, but we took an average of the, first we had 8 questions for knowledge. We took an average of those, and the score came out to be 83% approximately.
And 60% practices reporting of ADRs, right? Based on material vigilance.
Only 60%.
Yeah, 60% is not only, actually it is huge as compared to other studies.
Sir, we have some other studies from other countries as well, which have shown a score of 74% and 82% as well, but we are still lacking behind.
Okay, okay. Thank you. Thank you very much.
Thank you, sir.
Hello. Hello, sir. So Sunil here. Hello. Hello. Hello, sir.
Hello.
Hello, sir. Dr. Sunil here.
Hello.
Sir, Dr. Sunil here. I am here to present my presentation on.
Can you hear us, Dr. Sunil?
Yes, sir. I can hear you.
Okay, okay. Please go ahead. Please present within 1 minute. Okay.
Yes, sir. I am here. Myself, Dr. Sunil Kumar. I am here to present recent trends in adverse drug reaction reporting in Pharmacovigilance Program of India. As we all know, there are a number of ADR which go without reporting to Pharmacovigilance Program of India. To increase this reporting in the system, so our government has initiated the program PVPI in 2010, in order to more reporting, this digitalization is included. AMC centers are being created, toll-free number is created, and also the form is also digitalized. And big challenge was that the lack of time in reporting of clinical by clinicians, less number of ADR reporting, identification. And if we see because of benefit of this mobile app is there are two components, consumer component is there, healthcare component is there. The consumer, it means patient can also report the ADR because of this mobile app or digitalization. So benefit will be the increase in reporting of ADR will be there. And since 2000, the mobile app was launched, it has been downloaded by 5,000.
Dr. Sunil, my question is how you collect the data for the study?
Sir, I have seen through various articles, and then I decided, then I filled this data.
Means was there any systematic search for articles, or did you interview the policymakers, or did you go on through the websites, or what?
I just searched the articles, sir, through website, sir.
Okay, thank you,
sir. Welcome, sir. Thank you, sir.
Thank you all. We also thank our judges for spending their valuable time for the session. Now I ask Dr. Manisha Bis to felicitate Dr. Jayagran, sir.
Good afternoon, delegates. We are